Hi, everyone. Thank you so much for taking the time to hop on today's webinar. We know you're all extremely busy, therefore we really appreciate it. Today, you're going to hear from Dr. Melissa Womble, a neuropsychologist with specialization in sport concussion management, and Brett Gussman, a state licensed and nationally certified athletic trainer. This webinar will provide an review of concussions, including assessment, diagnosis, treatment, and prevention. So with that, I would like to introduce you to Dr. Melissa Womble and Brett Gussman. During the webinar, feel free to type any questions you have into the chat and we'll get to them at the end. This is a great opportunity to make sure you have the tools and knowledge to protect your athletes. So be sure to take advantage of these experts. Thanks and welcome, everyone.
All right. All right. Good afternoon, everybody, and thank you for joining us. I believe we're live and we're ready to go. My name is Brett Gustman. I am a licensed athletic trainer that works in the Inova Sports Medicine Concussion Program, along with Dr. Melissa Womble, who is the director of the Inova Sports Medicine Concussion Program. Today, we are going to be presenting information about concussions and a knowledge-based update to give you more information about concussions in today's day and age. So first, I would like to say thank you to QCOLLAR and to BSN for providing access to the Inova Health System's team of experts during Brain Injury Awareness Month. Today's objectives and what we will be covering are what's on the screen in front of you. That includes what is a concussion, the acute and sideline evaluation, at-home management, common myths and facts about concussion, what post-injury concussion care should look like, and in general, prevention of concussion. Just some basic facts about this injury. It is estimated that there is between 1.6 and 3.8 million sport-related concussions per year. High school athletes represent about 300,000 sport-related concussions per year. And that the research shows us that 10 to 15% of sport-related injuries are concussions, only secondary to ankle sprains. So exactly what is a concussion? Many people have misunderstanding of the definition of this injury. Very simply, a concussion is a disturbance of brain metabolism. It's an energy crisis that occurs when the brain is shaken around. There is no swelling or bruising in the brain. There's no bleeding in the brain. This is an energy crisis, and the brain is working less efficiently than it usually does. Because there is no swelling or bruising, imaging or special tests are not going to definitively show concussion. So our first myth that we'd like to bring up is that concussions only occur as a result of being hit directly in the head. And we can assure you that that's not the case at all. Concussions can occur whether you have a direct blow to the head, the face, the neck, or anywhere else in the body where the impact or the force is transmitted to the head. Think of a whiplash style mechanism that can occur without somebody ever hitting their head on a specific surface. Concussion only occurs when an athlete experiences a loss of consciousness. This is a common myth as well. In fact, concussions rarely occur with loss of consciousness. It's about 10% of the time that a loss of consciousness can occur. And what we know is that if a loss of consciousness is present, there is no outcome change because of the loss of consciousness or severity of injury change because of the loss of consciousness. What we look for, and as a coach especially, when you hear an athlete report that they feel dizzy right away, that is a red flag to ensure that that athlete does not return to the game. As you can see, what we've seen through research is that dizziness has a 7 times greater likelihood of predicting a longer term recovery following concussion. So how do we recognize concussion? What do we do to see this kind of invisible injury that may be occurring, right? When we have a big football hit and there's a broken arm, or if a kid loses a couple teeth or busts up his lip, it's clearly obvious that they require medical care. And so here's a little bit of a sideline funny for you. Obviously, if the kid's got smoke coming out of his head, we've got a bigger problem. But what is the idea? What's the goal for the coach or for the parent or for the onlooker to help determine who needs more evaluation or who may have sustained a concussion? Well, let's break down what exactly a sideline evaluation does. And any sideline evaluation, whether it's for an orthopedic injury or for a concussion, has the same three possible outcomes. What you're dealing with is an emergency situation. What you're dealing with can be monitored over time, or what you're dealing with is not an injury and the athlete has been safe and cleared to return to play. Here are some important parts of a sideline evaluation from a concussion standpoint. And it's important to understand that we are not diagnosing or making sure that an athlete has a concussion on the sideline. What we are doing is evaluating for suspicion of injury. And so in all suspected cases of concussion, the athlete should be removed from play. In the box on the right, I think it's important to understand that no matter what your background, no matter what level of training you have, as best as you can do, sometimes concussion symptoms don't show themselves right away. And so erring on the side of caution always protects the athlete in the acute situation. What is generally expected or required of an appropriate sideline evaluation is listed on the left. And you can see that includes both cognitive screening, balance testing, a full neurological exam, a vestibular and ocular motor assessment, as well as exertion testing. As you as a coach stands, your goal, as we talked about a minute ago, is to determine if this is an emergency situation. That's the first challenge you have, right? At that point, we're likely not dealing with a concussion. Our concern is something more significant than a concussion. I'll never stop a parent who has the desire to take their son or daughter to the emergency room or for further care. If they're not comfortable with the way that their son or daughter looks, by all means, they should be evaluated acutely. But these are the signs and symptoms that you may see or notice with your student athletes that would indicate to you that an emergency visit is more warranted. And you can see the list. Headaches that are worsening, loss of consciousness, as we talked about, should be evaluated at the emergency room. Vomiting is a common one, and what we talk about with vomiting is not so much of an individual incidence of vomiting, but more something along an uncontrolled pattern or consistent vomiting. It's not uncommon at all for any sort of traumatic injury, whether you've broken your arm or a head injury, to maybe experience some immediate vomiting. But something that persists over a period of time is something that we'd want to be assessed in an acute situation. And you can go through that list as well. Any focal or neurological symptoms should be assessed at the emergency room. Here are some common signs and symptoms of a concussion. And as we look through this list, we'll probably all giggle inside that that's some of us, some of the days, even without having an injury. And if you look at this list and you're familiar with teenagers, this can be them most days without even having a head injury. So sometimes it could be even more difficult. But following a traumatic blow to the body or head, we are looking for changes in symptoms that did not exist before the injury. And then on the left, we see the signs that are commonly associated with concussion. And the biggest difference, as you can appreciate, is signs of a concussion are things that we see outwardly, and then symptoms are what the patient would report to us. Let's move on to our next myth. And as we talked about, well, should know this right away, that it is safe for a player to return to the same game or practice after suffering concussion-related symptoms, and really that's the same thing as being suspected of a concussion. we briefly discussed that there are times when symptoms will not appear right away, and therefore taking the athlete out of play ensures that there are no symptoms that return within the next couple of hours post-injury. There should be no athlete that suffers any signs or symptoms return to the same game or practice, no matter how quickly symptoms may clear after a suspected injury. I'm going to turn the microphone over to Dr. Melissa Womble, and she's going to continue with some of the information.
Hi, everyone. So we're going to start off on this next part, just reviewing some research that has happened with concussion. And this article is looking at what happens if athletes continue to play following concussion. So what happens if they get a concussion and they continue to play in the game? So what happened in this paper is that they had 32 athletes that were removed immediately and 30 that continued to play. And what they found was that those that continued to play actually had an 8.8 times greater risk for prolonged recovery. So just playing a couple more minutes actually resulted in a longer recovery time. Additionally, neurocognitive and symptom data collected at the different time points, 1 to 7 days and then 8 to 30 days, were worse for the group that continued to play. So really, the takeaway from this study is that immediate removal from play is the first step in mitigating the prolonged concussion recovery. It was kind of one of the hallmark studies showing the importance of removal from play. And this was really in support of what the consensus statements have said with regards to concussion in terms of removing any suspected individual from play immediately. Now, there was a follow-up study to this, and the title of it is there a dose response for a longer recovery in athletes who continue to play following concussion? And what they did is they looked at 52 athletes that were immediately removed, and then 24 that continued to play greater than or equal to 15 minutes, and then 32 that continued to play even longer than that. And what you can see here, the amount of days for recovery. So they immediately removed were recovered on average within 18.9 days. Those that continued for less than 15 minutes had a recovery around 28.4 days. And then those that continued to play for greater than 15 minutes had a recovery around 44 days. So there was a 5.3 times greater likelihood for prolonged recovery in the short play, those that continued to play for a short amount of time, and 11.76 times greater risk for prolonged recovery in the long play group. So it's pretty substantial in terms of the difference playing for less than 15 minutes or greater than 15 minutes. And both play groups had worse neurocognitive performance and higher symptoms than the removed group. So again, just kind of a recap of these studies. Those that continued to play had greater symptoms, worse memory scores, and longer or greater reaction. Their reaction time was worse. Athletes who stayed in the game with a concussion took at least twice as long to recover, and then continuing to play for just a few minutes can inversely have effects on recovery time. So as far as post-injury management, what should this look like? You know, prior to the season, we definitely recommend baseline testing. It's really important to kind of have that snapshot of an athlete prior to an injury happening. And that's a snapshot in terms of how they normally function as far as their memory scores, their processing speed, and their reaction time, which are the areas that we know can be affected post-concussion. Then that concussion happens. And, you know, based on what Brett said, we kind of decide, is an acute care visit needed? Meaning, do they need to go to the ER and urgent care right away to rule out a more significant injury like a structural injury? And then generally their first post-injury evaluation should be about 1 to 3 days post-injury. We often find in our clinic that, you know, around that 3-day mark is kind of the ideal point for athletes to be evaluated. They're no longer having that huge symptom burden that we can see in that first 72 hours. So usually we recommend evaluation about 3 days post-injury. And then they follow up with the physician as needed until they get cleared for return to play. And this can vary, from patient to patient in terms of how much time this takes. We know most injuries resolve in about 1 to 4 weeks. So back to our myths, a common myth that we hear is that you must be placed in a dark room to recover from concussion. And this has changed a lot over time. We no longer recommend strict rest. What we used to think about concussion was that there's really nothing we can do for concussion. There really are no treatments for this injury. You need to rest. No physical or cognitive activities until your symptoms are resolved, then we'll gradually introduce activity. But what we are finding are, when we think about rest, there really were no well-defined studies about rest in terms of what it looks like, the type of rest that's needed, the timing of the rest, the dose or the frequency. Really, the thought process behind it is it's avoiding or mitigating the exertion and during physical and mental activities such as sports, exercise, phone use, social activities, school, etc. And I think a lot of patients think if some is good, more must be better. But there's actually, interestingly, no research that demonstrates using a cell phone or watching TV is detrimental. And so that's a common thing that patients think. Unfortunately, when patients rest and they go into that dark room, then anxiety can increase. And anxiety is a very common thing that we see in clinic post this injury, especially in those that have been in more of this rest situation. And so we really have to talk to patients about avoiding or how the avoidance of certain activities may reduce that anxiety temporarily, but maintain it over time. So we really want them to expose to some of these situations that cause symptoms. We actually know that you have to feel some symptoms to get better with concussion. And so we want to prevent those avoidant behaviors, foster some of those coping strategies and processing of new learning and corrective information that can help them overcome symptoms, and gradually engage in the habituation to symptoms over time through repeated trials. So we often talk to patients about, you have to expose to get better. So you have to do some of those things that cause symptoms and then take breaks to manage the symptoms. So usually we say if they get to like a 5 out of 10 level symptom, then they'll take a break at that point. So that's an important thing, as coaches to understand that even while your athletes are still symptomatic, they may benefit from some non-contact, lower level physical activity. And even if it provokes a little bit of symptoms, as long as it's keeping them in that more mild range, kind of that 0 to 4 out of 10 range, that can actually be helpful for recovery. Now back to this whole concept of rest, really kind of one of the main studies that kind of made the pendulum swing on rest was the study by Thomas and colleagues. And it was a randomized controlled trial out of the ER. And basically what happened is adolescents were randomly selected for a strict rest group versus a usual care. And those in the strict rest group actually reported more daily post-concussion symptoms and demonstrated a longer recovery. And the thought process behind these results was that emotional distress can be caused by missing school and work, falling behind, activity restrictions, missing those social interactions. And it actually can cause a situational depression that can cause increased physical and emotional symptoms. So how Brett mentioned, a lot of these symptoms, we can see in just our adolescents normally, but we can see them in other conditions as well. Depression, anxiety, can result in many of the symptoms that we see post-concussion. So the activity restrictions and lack of a normal schedule is really suspected to be a detriment to recovery. So as far as kind of combating this myth, really the fact behind this is that strict rest has actually been shown to cause individuals with concussion to experience greater symptoms and prolonged recoveries. This is from the latest consensus statement. There's going to be a new one coming out, but it's really, the latest consensus statement actually really encourages activity after that first 24, 48 hours. So I'm just going to read this statement. There is currently insufficient evidence that prescribing complete rest achieves these objectives. After a brief period of rest during the acute phase 24 to 48 hours after injury, patients can be encouraged to become gradually and progressively more active while staying below their cognitive and physical symptom exacerbation thresholds. That is, activity levels should not bring on or worsen their symptoms. It is reasonable for athletes to avoid vigorous exertion while they are recovering. The exact amount and duration of rest is not yet well defined in the literature and requires further study. So that's where we go back to the pendulum's kind of shifting, but what we're finding out is strict rest is not beneficial. Probably the most activity you can do is not beneficial, so it's somewhere in that middle point. So as far as treatment, this is kind of a newer thing with concussion and recognizing that treatments are available. If we're not saying just go to a dark room, what are we doing with patients? And a lot of patients simply benefit from behavioral regulation. We're going to talk a little bit about that on the next slide, but it's addressing their sleep, their physical activity level, nutrition, hydration, and stress management. There's also active therapies. So not every concussion is the same, and we really try to figure out which profile or profiles the patient is hitting. So you can see this diagram here, and it's been proposed in the literature that there's 5 different types of concussion. So there can be anxiety and mood, vestibular, ocular, cognitive fatigue, or a post-traumatic migraine. And so our goal in clinic is to identify which profile or profiles our patients are hitting so that we can individualize that treatment plan. So a little bit about the profiles, just so you'll understand that, is that anxiety and mood is just what you think. There's more anxiety present than typically before the injury. A lot of rumination can happen. That can result in some of the physical symptoms. Vestibular is your difficulty coordinating your head and eye movement. You may experience dizziness after concussion. Ocular is where we see the muscles of the eyes are not working the way that they typically do, and that can cause problems with school activities, reading, tracking the ball, things like that. Cause a lot of frontal-based headaches. Cognitive fatigue is kind of an overwhelming sense of fatigue that prevents engagement and activity, and it can be something that we actually use physical activity to overcome. And then post-traumatic migraine is just kind of what it sounds like. It's a migraine that happens post-injury, usually more unilateral headache with nausea and light or noise sensitivity. Now, as far as the active therapies that we have to combat some of these, we have vestibular therapy, we have exertion therapy. In some cases, if we need it, we have vision therapy. In some cases, we also have to use medication management, but that's more rare. And the most important thing is to make sure that the treatment is individualized to the patient, so it's matching onto the profile that we're suspecting. Now, as far as behavioral management, I mentioned that as kind of one of the main things that we need to do with patients. And this is something, especially even as a coach, if you feel like your athlete's getting kind of poor care, you can kind of check in on these things, but we want to make sure that athletes are, eating breakfast, lunch, and dinner each day. It's amazing how many at baseline don't do this, but when you're having this energy crisis after concussion, your brain needs that fuel to get better. So you really have to think about the food as the fuel to get better. Same with hydration. We really want them staying well hydrated. Sticking to a strict sleep schedule with regular bed and wake up times, especially when they get out of school, though we usually like to get them back to school as soon as possible. Sometimes their sleep routines get really messed up. And so we generally want patients to get about 7 to 9 hours a night with limited to no naps. And generally, if they nap, 30 minutes or less. Daily physical activity is encouraged. Anyone with a concussion can walk. It's important for them to get some activity, especially if that's normally their way of releasing their stress and kind of their outlet. And once they're seen by a physician, then it can be determined what level of activity they're able to engage in. But at a minimum, anyone can walk or go on a stationary bike. That's actually good for them. So even having them come out to the field and just walk around as an initial step would be good. And then trying to keep stress as reduced as we can for the individual. That's really important. Stress is a big component following this injury, and so we want to try to keep that at a minimum. So sometimes I'll even say, kind of reduce the focus on the injury, try to make athletes feel more normal. Don't always have to be asking about their symptoms too. Sometimes that increases their stress and anxiety. Now, the next myth is having one concussion places you at increased risk for future concussions. And what we know is that actually well-managed concussions, in full recovery, should not place, they should not be at any more increased risk for future concussions. Really, proper clinical management is the best form of prevention. But that's an important thing. We see a lot of injuries that go mismanaged. They're kind of being managed by a parent, they're being managed by a neighbor, things where they're not getting the proper care, and sometimes things go missed and the athlete's actually not fully resolved. Also, we do know that some pre-existing conditions, for example, migraines, car sickness, history of lazy eye, can place the athlete at higher risk for injury. So if we line up 100 kids, those with that history, either personal or family, could be a little more at risk for injury, but it shouldn't be the previous concussion that puts them at greater risk for another injury, as long as that's fully recovered. Another myth is that all concussions, treatments, and recoveries are alike. And as we discussed, there are different types of concussions, and that's really where this field has changed, in that we really try to individualize this and figure out, what profile or profiles they're hitting, so that we can individualize the treatment. And this is just a little comic saying, look up, look down, look at my thumb, gee, or quit messing around, doc. Does he have a concussion or not? And what we know with concussion is it's complicated, and the evaluation for concussion definitely has to be comprehensive. There's not one test that definitively diagnoses the injury. So as part of our comprehensive clinical assessment, we're always doing a detailed clinical interview, vestibular and ocular motor screening, and computerized neurocognitive testing. In some cases, we'll also do physical exertion with the athlete to figure out how they respond to that. But it's using all of these different tools together to establish that diagnosis and prognosis, establish the clinical and treatment profiles or trajectories, and then establish that treatment and rehabilitation plan. It's really, really important to put all of those data points together. If I just relied on symptoms alone, I would be putting athletes back to play sooner than they should every day. So it's really using all these different pieces to make sure that all of the systems that we know can be affected post-concussion are back to normal. So I'm going to turn it back over to Brett to talk about prevention.
Sorry about that. Okay, so prevention is a big topic, right? And especially those that are engaged in contact or collision sports, what we're seeing a lot now is ways to help reduce concussion, or maybe reduce the severity of concussion. And so, as Dr. Womble talked about, the first thing to recognize and appreciate is that some athletes, some of us, are, as we have learned from research, or may be more predisposed to concussion from the start. Again, migraines, people with lazy eye, and conditions like that might be predisposed to concussion. So what do we do for prevention to help reduce this injury? Well, as Dr. Womble talked about, baseline testing is a very important tool in the arsenal of recovery from concussion, and so that obviously starts before an injury occurs. When we talk about baseline testing, this is a brief neurocognitive assessment tool. There are multiple tools out there to be used, and they look at generally the same different tasks of visual, verbal memory, and reaction time, and these tools are used post-injury to help determine if there are any cognitive deficits compared to pre-injury. Protective gear is a large part of concussion prevention. There is a lot of information out there, and I wanted to provide you with some unbiased resources for your athletes to look at. Football helmets, as well as all helmets, are looked at and rated by Virginia Tech in an unbiased study, and they put all of their information out on the web. This doesn't mean that your helmet is going to be concussion proof. And what they do is they look at these studies without the bias of cost. And so you can appreciate when you look at this website that there are helmets that cost extremely high levels of dollars and helmets that are very inexpensive that have similar ratings. And you can help guide your student athletes towards making clinically good decisions. In the end, the best helmet is the helmet that is worn correctly and with compliance. And that's the biggest goal. There are a lot of other devices being developed and researched with regards to the ability to prevent against concussion, or at a minimum, reduce the risk for injury. And you might have seen some information regarding mouth guards, soft helmets during football practice, scrum hats or headbands for different sports, accelerometers, biomarkers, or even the QCOLLAR. And the QCOLLAR is an interesting piece of equipment that's been getting a lot of attention recently. It is the only device that has been reviewed and cleared by the FDA to help protection against brain injury associated with repetitive head impacts. We encourage you to understand the purpose of the equipment that you're going to wear and the research behind it. This is where we're reaching the end of our presentation. Dr. Womble and I would be more than happy to entertain questions about our show or anything else that might be pertinent to this topic.
Awesome. Well, thank you so much for the great information, both Melissa and Brett. Let me go ahead and spotlight you guys. Cool. We did get one question that just came in, asking if you can talk a little bit more about how the QCOLLAR concussions.
Sorry, you cut out there for just a second.
Oh, sorry about that. We got a question asking if you could talk a little bit more about the QCOLLAR and how it works to kind of help prevent concussions.
Sure. So, from what I know, and I'm not an expert in QCOLLAR, is because the brain floats inside the skull, it moves sometimes with greater force, and when the head is exposed to an impact. And so what QCOLLAR does is it applies light pressure to the sides of the neck, and that increases blood volume in the brain's venous structures, and that reduces the harmful internal movement that can cause brain injury.
Great, thank you. The next question, Karen asked, what is your opinion on the use of guardian caps in cheerleading?
So guardian caps, as well as all of the headbands, I think that when you talk about cheerleading and especially with flyers, that seems to be the biggest area, and then their bases with the elbows coming down. Again, I think I would defer generally towards the Virginia Tech website to look at some of the research based on those. It's important to understand that all of these devices, while they're trying to reduce the force, there are many unknowns, and we're not totally sure of every single individual's threshold for concussion. So while it might be a useful device for some, it might not be for others.
Awesome. And then John asked, our high school used to do baseline testing back in around 2016, but a few years later stopped baseline testing. Why do you think that might be?
It's an interesting question. I mean, I'm sure there's a lot of different moving pieces to it. Baseline testing can be pretty time intensive. And we've seen, a reduction in athletic training staff post-COVID. So I think, sometimes that has been a factor in less schools doing baseline testing. Also, there is a cost to it. And so, I think those two pieces have prevented it from being used in every school all of the time. But I do think it's important, and it's important for even, in those schools where it's not done, that it, parents consider it, especially if their athlete is in multiple sports and getting exposed to a lot of contact. It's, sometimes we look at the data and we're like, wow, in terms of the post-injury data versus the baseline, really the baseline data can be very valuable in a lot of cases, especially in cases where kids have like ADHD or learning disability.
I think it's important too to understand, especially with regards to the topic of neurocognitive testing, that it is not a concussion test. It is just, like Dr. Womble said, another tool that can be used to help support return to play or any return to learn decisions. And it can be useful in either speeding up a progression or sometimes making sure that the athlete is safe to go. And so while baseline testing might not be available, it is very much encouraged to try and bring that to your community and allow those student athletes to receive that service before an injury occurs.
Great. And then we got a question asking, so they've heard that 3 concussions and athletes should cease playing. Sometimes they hear 5. Is there a number of concussions that the athlete should no longer play contact sports?
No, there's not a number. 3 is the common one. Usually parents come frantic when they've had their child's had number 3. But 3 comes out of somebody's back pocket. There's no scientific research to support that. Really what we look at, there's kind of 3 factors: is how close in time are injuries happening? What is the force of the injury that's creating, is the force getting less as more and more injuries happen? So for example, somebody hitting their head on the kitchen doorknob or cabinet knob that we all kind of bonk our heads on at times. Or is the injuries taking longer and longer to recover? So those are really the factors as professionals that we look at to determine if it may be the point where somebody needs to consider a different sport or different mechanism of physical activity, but that's pretty rare.
Awesome, great answer. And then Dan asked, do you feel the NFHS High School Rules Committee has addressed post-concussion protocols satisfactorily?
I think that while all of our organizations continue to work towards the ultimate goal of having fantastic outcomes at every turn with concussion, there's a lot still to be done. I think that at the local level and then bringing it up even to the national level, greater standards need to be accomplished across the board. We also need to have better healthcare services and providing athletic training services to more high schools. It's unfortunate that there are too many high schools throughout the United States where the student athletes with contact or collision sports do not have access to proper medical healthcare during sporting events. And that in itself can put a coach in a difficult situation or a parent in a difficult situation with return to play and making a biased decision. You know, we're all invested in the game and our athletes, and sometimes when we are that invested, our decision could be a little bit more biased, even unintentionally. So while the NFHS continues to improve their rules, we need to continue to support higher quality medical health care during athletic events.
Cool, thank you. And then Daniel asks, are there potential negative side effects of wearing the QCOLLAR? And have the effects been studied both short-term and long-term?
I would say, I'm not an expert in QCOLLAR. I don't know if Charlie wants to jump on to answer that question as far as, negative side effects. I don't know any, but I also, again, I'm not well versed. I know the company has done a lot of different studies, and certainly it sounds like they have more studies on the horizon.
Yeah, I can jump in on that. Hey, everyone, I'm Charlie. So in terms of side effects, no, there are no reported adverse events that have been reported to us either, live in market or from, during any of our testing, and through the FDA clearance process. So, based on how the QCOLLAR works, there really is no risk of athletic performance or any impact on, the blood flow throughout your body or anything like that. So it is deemed a low risk device, which is by the FDA. So from that perspective, really no risk, though, some athletes, it can take them a couple of days to get used to just because, the sensation of having something around their neck is a little foreign. And then in terms of short and long-term effects, or studies rather, a lot of the performance testing and safety testing was obviously, measured more on a direct, active wearing basis. In terms of longer term studies, a lot of that, for our clinical trials, we looked at athletes before and after the season using MRI technology. So that was after, before and after an entire season of play to determine, the impact on their white matter brain tissue. So, and in regards to that, both from a impact of wearing the collar on their brain health, as well as, safety and athletic performance and things of that nature. So, studies have been done with that kind of look back, but there hasn't been, anything longer term from a clinical perspective over the course of multiple years or seasons.
Great. Thank you for that insight, Charlie. And I apologize if I mispronounce this next one, but Eleni asked, for soccer, in terms of headers and the added risk goalies face, do you have any suggestions for safety gear? I teach at an elementary school and am wary of having the youth do headers because they are so young. Am I wrong here, or is there a reason for me to worry?
So USA Soccer has some guidelines out with regards to age specific roles in heading and learning how to head. But I will say that from a soccer perspective, the most important heading aspect is technique. And there are many different drills out there that can be done appropriately to teach technique using progression of soft soccer balls and building up. Repetitive overuse is not a good idea in any body part. And so if you had obviously a kid stand in line and throw them 50 headers in a row, that's probably not appropriate. But starting with technique and working small and progression up is the most appropriate way. Again, I would defer. If you're a soccer coach, I would certainly look at the guidelines that USA Soccer puts out. They do a nice job of outlining what they expect a progression for heading knowledge is and at what age they define where the appropriate heading roles would be. As far as equipment goes, this goes back to, again, some of the roles of some of the headbands and different devices that are out there. I think it's very important to understand the role of each device, what its function is, what the positives and negatives are, and weigh that appropriately for you and the student athlete in each situation.